Hello and welcome to another podcast here at the Emergency Services Show. We're here this afternoon with Steve Jephcote, and Steve is the mental health lead over at South Central Ambulance Service. Steve, thank you for coming and being with us and having a chat with us about mental health. Why don't you just go ahead and start by telling people what your background is, where you come from, what your experience is, and then we can launch into a chat together and see where it goes.
No worries. Thank you very much for having me. I'm Steve Jephcote. I'm the clinical lead mental health and learning disability over at South Central Ambulance. I'm a mental health nurse by background, previously working in CAMS crisis, inpatient personality disorder care, the usual kind of mental health nursing sort of background.
Great. So, really broad experience, particularly in some of those crisis settings where, we very much have that overlap, don't we, in terms of the work we do as an ambulance service
Absolutely.
and the work we see in what I would say core mental health services, as it were, recognising that obviously we still act in that way as a mental health service. And I think it's probably there we wanted to start, really, and sort of discuss our role actually in one of the most formal parts of what we do day in, day out in 136, Section 136 of the Mental Health Act.
Yeah, it's one of those areas I feel that we as ambulance services have an everlasting input into it, but it's also probably one of those areas where people feel the less confident. It's a fairly regular part of our day-to-day work, but it is also one of those where we may not necessarily provide as much training for our crews as we potentially might need to.
Yeah, absolutely. And I think for me, we see, certainly crews are engaging in those kind of practices very regularly. They'll be very, aware of the terminology, but I'm not necessarily sure they'll always totally understand the legislation, perhaps their responsibilities and their role and why we do what we do. So I think it's probably helpful to touch on, the why we are actually involved in this in the first place. It's a policing power. Why should the ambulance be involved in Section 136?
So, as probably we all know, there's a couple of different aspects of the Act, and this particular section that we as ambulance services can be involved in, not least of which the conveyance of anyone who's been detained under the Act. These people that are being detained by police, they are patients, they are not prisoners, they are absolutely entitled to be treated as such, and therefore an ambulance in most cases is absolutely the right method of conveyance that we should be looking at. Likewise, paramedics, particularly nurses, are on the list of professionals that police, where practicable, should be consulting with before those detentions are placed. Being realistic in that actually in many cases it's not practicable to liaise or speak with anybody that can provide a medical oversight, but where it is, then paramedics, nurses, medical practitioners absolutely are being consulted and should be.
Absolutely. So we know that Section 136 does place that requirement where practicable to actually consult with a mental health nurse, an AMP, a registered medical practitioner, a social worker, and actually a whole range of other professionals that were added onto that list very quickly, actually, after those regulations changed. So, but yeah, I don't think staff, I don't think police, I don't think other professions necessarily fully know that is the case. And for me, I think, often we can end up in that same space where the lesser practicable detentions are happening because by our very nature, we co-respond and turn up to emergency situations with police. And actually, even where that is a nod across the room, well, not the room, sorry, let me clarify, not across the side of the pavement or the park, we'll come on to where 136 can be applied. But even if that's just a nod to each other to say, actually, I think this is necessary, that is a form of consultation and actually would formally satisfy the law. Now, if we've got more opportunity to have more of a discussion, I think that's great. And if there's even more opportunity to have a discussion with other external services, so crisis teams, AMP services, depending on local protocols and processes, that's got to be a good thing, right?
Absolutely. And we can never take away. The detention itself is a police power.
Yeah.
It is always at the decision of the police constable of any rank that is on scene to make that decision. Our involvement is to give an opinion. The officer in question doesn't necessarily have to take that opinion, but it is there to safeguard ourselves, the officers, and most importantly, the patient.
And I think we've got to acknowledge there's inherent risks in that as well. So, when we have discussion around consultations, actually, we're starting to talk into some of that language of what 136 actually is. So, the very first part of that is appears to a constable to be a need of this happening in layman's terms.
Mm-hmm.
Tell me what that means to you, and what are the pitfalls around that language in terms of how we can perhaps disregard some sort of presentations.
And this is always the issue when it comes to anything like this. Any form of assessment is always subjective and objective. What I might see with my professional background might be completely different to yourself with yours, might be completely different to the police officer that's on scene with us. Therefore, the opinions that we will give will always be based upon what our own backgrounds and experiences will be. Therein lies the inherent difficulties with things like this. If we're in a situation where somebody is very clearly very distressed, they're in a particularly dangerous situation, and we need to be involved in order to keep them safe, it may be that at that point, Section 136 is potentially applicable. However, it doesn't necessarily mean that it's an automatic thing, and it absolutely shouldn't be.
Yeah.
Because at the end of the day, we are depriving somebody of their liberty at that moment in time, where if there are alternatives, we absolutely should be seeking those out as well.
Yeah, and I think it'd be really helpful just to explore and to give people a bit of a sense of what those alternatives can look like, because I think you're absolutely right. Distress is a big thing and a big part of that presentation so often for us, as is, the presenting level of risk and the necessity ultimately to impose restriction on a person in the form of that legal power. But what can we do before we get to that level? How can we, reduce that level of distress to support engagement, to reduce the need for those restrictive means?
Whatever we can do to, and it's going to be the magic words of de-escalate the situation, anything we can do to help manage that person to deal with whatever it is that's the concern at that point in time. It's really difficult to try and give examples of what these might be, because all of these issues are always going to be entirely at the moment. But at the end of the day, taking time with our patient is more often than not the way we can do this if the situation presents itself that we can. It's not always the case that time is our friend, and sometimes in those situations actually it's not, which is where those emergency decisions have to be taken. But if we are able to, sometimes spending that little bit of extra time on scene to help to look after our patient in a bespoke and holistic fashion absolutely pays dividends in the long run.
Absolutely. So I think for me, and obviously we collaborated on rewriting the mental health guideline a few years ago, didn't we?
We did.
But yeah, things like building rapport with the patient is so important. Give them that opportunity to develop trust in you, to know that actually you're for them, that you want to actually support them through what's going on, and that actually you don't want to do some of the things that they would rather not do if we can avoid it. Because so often patients don't want to be detained under Section 136. They will actually actively work with us to avoid that if we can achieve that. Validating distress.
Yeah.
Accepting that someone is all right to be upset about a certain situation. I mean, we do see a lot of social triggers for many episodes of psychiatric distress, whether that be financial, whether that be relational. There's a whole number of reasons that a person might move from a position of thinking about suicide to taking an act, or either self-harm or harming someone else, all of the sort of risk domains that might lead to the use of 136. So going from that position of actually thinking about it to doing it is a big step, but it's so often that trigger, and it's, for me, accepting that what they've experienced is okay.
Yeah, absolutely. Everyone is entitled to manage their own experiences and their own distress in their own way.
Yeah.
We are there to try and help them through that. I do sometimes receive the question of, well, what's the ambulance service role in regards to mental health care overall? And actually, mental health care has as much right to be looked after by the ambulance service as physical health care does. A patient is a patient. We need to look after our patients. That's what we join the service to do.
Yeah, and I think for me, it's about, and we've said actually this earlier with our previous guests, but it's about moving away from this space where we think of skills and interventions purely as the things that we poke into people, and the interventions we do, our communication, the way that we engage with people in mental health care as well as in physical health care is so important. And I think we do gloss over that so often, and don't practice it perhaps in the way that we should do, or reflect on how we do that. And I think that's a really important part of that process as well.
Definitely. I often hear to them being referred to as soft skills, and I'm not a huge fan of the term because it implies that
they're really hard to start with.
Yeah, it implies that actually everyone's got them and it'll be fine, you just kind of roll with it. But actually, as with any skill, if you don't practice it, if you don't develop it, then it's probably not going to be particularly effective at the point of need. We, as healthcare professionals, supposedly are really good at communication and really good on being able to do these soft skills. But actually, it doesn't mean that they do come naturally, and in many cases, actually, we do need to practice more.
Absolutely. So, de-escalation, validation, there's other things, sort of ventilation, allowing people to speak, reassurance, simple reassurance, just saying, look, there are people there to help and support you. These are all really powerful tools. And obviously, for anyone who wants to sort of read a bit more about that, they are plumbed into the JRCAT guidelines. So there's loads of information there, along with all the assessment and management and risk assessment processes that we've put in there. Once we've obviously de-escalated, it then brings up that opportunity to think about that alternative service. So I know certainly for me, we've got a range of services locally within West Mids. How about South Central? What does that look like for you guys? Because they should really be fairly similar, you'd hope.
They should be. I think it's probably fair to say for South Central as it is for West Midlands, in certain cases it's pretty much dependent upon where you are. The fallback that everyone looks at is emergency departments, but we have a very good relationship with our mental health provider trusts. They are embedded into our 111 services as telephone triage services. That's spread across the whole of our geography. The crisis teams, we have in certain areas we have direct access to our crisis services and our crisis team bases. The announcements of crisis assessment centres, although we don't have any confirmation on where they will be just yet, we are very much looking forward to hopefully receiving those at some point in the future. All of our clinical pathways are frankly available to our crews. We want them to be used. That's the whole point of having them. It may be that a phone call to the local community mental health team or the local crisis and home treatment teams may be enough to look after this person and to avoid having to look at whether we do need to take this person to ED. It may be that actually ED may be the correct place. And it may be that actually we need to look at alternative services as well.
And I think that's the important thing, isn't it? We've got to put all of that in the balance. And to do that, we need information both around how the patient's presenting to us and what the risk is and what their expectations are, what we can actually do to mitigate any of that. But also there's a physical health assessment part of that as well. So, when deciding that determination between am I going to ED, am I going to a crisis cafe or a safe haven, we need to have that information. So we need to be doing full holistic clinical assessments that cover off both the physical health and obviously, of course, then the mental state examination, the risk assessment, gathering proper history, and pulling that together as part of a structured clinical judgment to help underline basically our clinical decision making. And as we do that, that supports really good documentation, really good evidence of our processes.
Absolutely. It all goes back to the statement of parity of esteem. Physical health and mental health both work together to build the person. By doing the assessments and by looking at both elements of this person, we build that holistic viewpoint. It doesn't have to be that you've been called out for a mental health based concern. It doesn't have to be that you've been called out for a physical health based concern. We combine both for every patient because every patient has got both elements of that.
Absolutely, and I think we're equally as bad as I don't want to criticise too much, but we're equally as poor sometimes at not including the mental health element and assessment when we experience patients with physical health needs, particularly where there may be long-term chronic conditions which are having an impact on people's mood and ability to function day in, day out, which could well be, a diagnosable condition which could well be treated either pharmacologically or through talking therapies or other forms of managing and supporting patients, which would actually lessen the impact of some of those physical conditions as well. And we know about making every contact count. It's embedded pretty much into all ambulance service education. But how often are we actually playing that out in real life and making sure that what we're outputting from a clinical perspective and what we're influencing in terms of patient outcomes reflects that?
Yeah, exactly that. It's I keep saying the word. It's holistic. We need to look at the whole patient, irrelevant of the reason for our call. We are looking at the whole person, and it is probably something that we don't do as well as we could do in many cases, but it is certainly something that we can do.
And I think for me, it's a great opportunity really to practice some of those skills as well. We recognise that historically ambulance service education around mental health act, mental capacity, all that kind of side of the work that we do and that you and I do day in, day out, we know that that's been challenging. And, we're seeing that nationally. HSIB released their investigation just yesterday into what some of that looks like and how those decisions are made and how we as an ambulance service triage and then respond and assess to those patients. So we know that there's a need to continue to review and continue to support our clinicians in that. But for our clinicians, there's a responsibility, particularly for our registered clinicians, to make sure that you're comfortable, that you have the right skills to assess and manage your patients. And that's through a process of self-reflection, of understanding what your limitations are, what your knowledge base is, and then proactively going out to search and find that information.
Yeah, and so in South Central, in the last year, 8% of our attended patients were presenting with a primary mental health presentation, which doesn't sound like a lot until you turn it into that's nearly 1 in 10, where actually the numbers change slightly at that point. And this is a growing sphere of operations for the ambulance service. It's something that historically weren't really involved in, but it's growing year in, year out now. And we need to be more comfortable in dealing with it. There is that responsibility upon, as you say, particularly upon our registered clinicians, but anyone with any form of patient contact, to be comfortable in what their role is. That role may be talking to somebody on the phone, It may be taking that initial call. It may be responding to them on scene. The opportunities are there for that CPD. They'll be either based within trust. They'll be sitting with third sector providers. They may be sitting with mental health providers where we are working alongside them to do particular aspects of training. There's a multitude of opportunities out there. Sometimes it is actually about taking that personal clinical responsibility to go out and find it and take that step to be a little bit more comfortable on something that historically we're not that comfortable with.
No, and I think, so often I think it can be seen as it's not the guts and glory, of most trauma, critical care. It's a very different approach to clinical interaction often, and certainly as a specialism, it's a very, very different approach. And but a lot of the skill sets, a lot of the critical thinking, a lot of the real satisfaction of doing a job well done can be achieved through that. So actually, I'd encourage people not to shy away from it because it's mental health, because it's difficult. I'd actually say, if you're recognising something as being difficult, as being a gap in your clinical care, run at it.
Absolutely.
Go and find those opportunities. Go and seek out the information. Email us, whether you're in trust, whether you're in another trust. Email us, because we're always happy to share that knowledge, because that's our passion. And that's why we do what we do. So we're always happy to do that. So certainly for West Mids colleagues and for SCAS colleagues, I'm sure, we both welcome emails. We both welcome people who are interested in showing a willingness to improve their skills and to learn. So, we get to a point, okay, we've perhaps considered those options around diverting people away from ED or avoiding Section 136. But sometimes that is necessary.
Yeah.
Let's just talk a little bit about that pathway and how that ends up and what that looks like and what those expectations may be, and perhaps a little bit even about how that's changed in terms of its expectation recently.
So I guess we have to be kind of realistic as to what the ambulance service input at that point is. And it is about, we maintain the welfare and the clinical care of that individual. The police may have made that decision to make that detention. It is a police power. It is a police detention. The police officer on scene holds the responsibility for that detention. But we hold the responsibility for the welfare of the individual. Wherever possible, that patient should be being conveyed in an ambulance. And we hold clinical responsibility up until the point that we hand over that care to an appropriate place of safety, be that Section 136 suites, health-based place of safety, an ED, or whatever is appropriate at that time for that individual. At that point, we are handing over to another clinician, be it liaison diversion, be it psychiatric liaison at ED, be it the mental health providers at 136 suite. At that point, as with all of our patients, our clinical responsibility is then done, but the police responsibility continues. So it seems fairly clear-cut for that element of it, and to a degree it probably is. But it's, again, making sure that we maintain an awareness of that responsibility throughout that episode of care.
Yeah, and I think for me particularly, those challenges around the non-compliant patient in that space that perhaps is being more heavily restrained, we've got to be aware of the risk factors. We've got to think about those other reasons that might necessitate us, perhaps rather than avoiding ED, going to ED rather than a Section 136 suite, health-based place safety, because some of those can be really high risk and really difficult to manage. So, typically we think of significant injuries, we think of head injuries, we think of severe intoxication, and sort of issues that are going to lead to an inability to clinically manage that patient within, and I use this slightly broadly, but in a non-medical setting, i.e. most often patients are supported and managed by a combination of registered mental health nurses, healthcare assistants, and then maybe some sort of psychiatric input in that waiting period. Ultimately, we know following a Section 136, it's likely that the person's going to be seen by 2 psychiatrists and an approved mental health professional. So actually, there will be input from doctors through the process. But fundamentally, these places are not EDs. They're not set up for high levels of clinical care. There's reduced access to medications. So, even the context of, drug overdose, for example, access to, or even withdrawal, frankly, access to medications to manage seizures as a result of withdrawal might be really challenging for mental health services. So in those cases where those risks are quite high, where we have done that clinical assessment, where we do think, and this is where I think we need to be a bit more holistic about our approach to risk assessment, because whether we're taking into 136 suite or whether we're discharging the patient on scene, things like, do they have means to access, continued use of a drug that they might be dependent on, is really important, and I think gets hugely under recognised.
Indeed, we have to bear in mind that most places of safety are nurse-led. It is unlikely that there will be a doctor on scene or at that place when patient arrives. Realistically, if the patient is requiring ongoing treatment of a physical nature, then ED is realistically going to be the most appropriate place for them, because it's there that they will be able to receive that, and that's where we would take anyone else.
But Steve, we're not a place of safety.
Well, unfortunately, in the eyes of the law, emergency departments are places of safety. The Royal College of Emergency Medicine guidelines do explicitly reinforce that as well.
They do, absolutely. So Section 135 of the Mental Health Act does define what is classed as a place of safety, and a hospital, regardless of the nature and type, is a place of safety in law. So you're absolutely right. And I think, we need to sort of challenge some of these pushbacks sometimes and actually say, no, I'm sorry, but you are, and we've done the right thing for the patient because we've done that assessment, we've made a decision, and it's well founded. And I understand, sometimes the challenge and pressures that mental health patients can put on emergency departments. We all know ourselves as clinicians, the pains of waiting outside EDs with patients who need to go in and be seen. And we know that mental health patients can spend long periods of time in departments, which is suboptimal, we must admit.
And we have to be recognisant of the gold standard of where patients should go would be a designated health-based place of safety, ideally a designate 136 suite or whatever they're called in your particular areas. But on occasion, when patients require an ED, patients require an ED.
Yeah.
And that's where we go. If they don't, and they do, we are looking at 136 suite, then certainly how it operates in the SCAS areas is that it is the responsibility of the detaining officers to find the appropriate place to go. From an ambulance point of view, we do the conveyance. We don't make the decision regarding the destination, apart from ED, where it's needed for physical healthcare. So actually, sometimes we might need to remind our colleagues that is the case.
Yeah, absolutely. That's really helpful. I think it might just be helpful to touch on that police decision as well, because there's sort of one place of safety that perhaps historically was used more than it ever should have been, and there are now reasons we shouldn't. So police custody. Tell me about police custody and 136.
Okay, so changes to the law indicate that custody should no longer be used as a place of safety, as a standard destination. There are times when it is appropriate, particularly in the cases of extreme violence, aggression, etc., but it does require the sign-off of a senior officer to do so. It's also worth bearing in mind that actually certainly in SCAS, we do get a number of detentions in custody. That is not the case that when that person has been detained in custody, that custody remains the appropriate place. We are then looking to move to an appropriate destination at that point. But yeah, so since those changes have come in, there have been the usual tick over, I guess, whenever there is a change in legislation. But certainly in our area, that has actually been rolled out fairly well, and there hasn't been any particular difficulties in changes. Hopefully that's the same.
Yeah, absolutely. So very similar, police have that responsibility. We need that senior officer input, and we want to try and move someone out from a custody setting if they have been detained under the Act in that space into a health-based place of safety wherever we can. And I think, often it can appear quite frustrating, can't it? Because you're already in this place, but the law remains the law, and actually we still do need that senior officer authorisation for exceptional circumstances to be able to do that. And as you rightly say, the significant levels of violence and aggression are obviously, are very often, that threshold that we look to. However, I think there's always got to be a bit of caution about that because of the etiology of how that violence and aggression presents.
Yes.
And whether custody is the right healthcare environment to manage the potential etiology of those kind of presentations. So we know, the cognitive impairment as a result of head injury leading to violence and aggression.
Yeah.
How do police rule that out? We know that significant substance overdose may lead to those kind of presentations. How do we rule that out? If we think about acute behavioural disturbance, which acknowledging, it is a controversial topic in and of itself, but I think we all recognise that prolonged use of restraint or restriction in any way, shape or form for a patient in that level of arousal is a really dangerous thing. So, thankfully we're in a place where that's so often recognised, so often escalated. But I think we've got to be really cautious around when we're asking or when we're advising or when we're giving, support to police around that sort of decision making to say, actually, okay, I can kind of see why you might want to potentially just nick him or her as a result of offences where there might be discussion between 136 and arrest, or indeed where you've gone for the 136 and there is that discussion between custody and ED.
Yeah, but it takes us back to the very start, doesn't it? It goes back to that, from our point of view, as an ambulance service crew, we hold the physical responsibility for that person's clinical presentation. It is our clinical decision as to where they need to be.
Yep.
If we are not comfortable with them being in a custody suite, then we need to say very clearly, actually, this is my viewpoint as a clinician. I will be taking my patient to wherever.
Yeah, and I think, we've got to be in a position where we are comfortable to challenge other professionals as well, particularly police. We can very often see police as being the authoritative, service, and they are the legal professionals are so often in the space, but it doesn't mean that they get things right all the time, and it doesn't mean that they are always looking or considering circumstances through our lens and particular sort of approach to a situation, circumstance or decision. And I think for us, certainly colleagues within West Mids will be very familiar, and I suspect in SCAS and the wider systems as well, in terms of escalating concern. So using the CUS principles, concern, uncomfortable, safety issue, stop if you want to add a second S in, which is sort of more and more common. So if we're concerned, just voice that, use the word concerned and express that. If we're uncomfortable with something, say we're uncomfortable with it. If there is a direct safety issue that means that this really shouldn't be happening, say that. And if we just need to stop and think again, say the word stop. Because actually, officers are kind of so often expecting certain keywords and phrases, and those sort of align to some of what they would expect to hear and see, and may just prompt that better response from them.
Yeah, and one of the big pushes that I put into any of the training that I deliver within our service is don't take decisions in isolation if you're not comfortable. This is what we have an escalation chain for. It's not a declaration of incompetence. It's not a declaration of not being comfortable in what you're doing. It's a declaration of, actually, I need some backup.
Yeah.
Because more often than not, the decision you want to make is correct. Because it usually is. But having that managerial backup, having that clinical backup, so going through the line of your team leader, going through the line of your local management, going through the line of medical incident advisors or urgent care desks or whatever your local equivalents are, either pathway will provide that backup. Both pathways together will provide that backup. We don't encourage people to make those decisions in isolation. They are there. These pathways are there. These systems are there in order to look after our patient, look after our staff, and be able to make the right decision for that person at that time.
And I think, we're so used to taking that approach in other areas as well. Increasingly the application of JESIP principles into, how we respond to incidents that aren't necessarily major incidents, so severe, serious incidents, your car crashes, your patient on the bridge, but actually this is a set of tools that can be really powerful in terms of working particularly with police, fire, statutory agencies, but increasingly, even if applied from a one-sided perspective, can give a framework to having a discussion and getting to a sensible endpoint. So, for colleagues who are, in practice making these decisions, who are unsure, absolutely reach out, speak to crisis teams, speak to our single point of access number we have locally. Go and speak to the people that can help with the clinical side of it, but also start to think of how can we structure this decision so that it makes sense. And if you are going around thinking about information intelligence, you are thinking about risks and what we want to achieve, you are thinking about powers and policies, options, contingencies, and then taking action and thinking, how did that go? Do we need to change a plan? Well, and if you've documented that, so much the better, because you will get from point A to point B and be able to have a logical flow of what you've done, how you've done it, why you've done it, and that's good for the patient because we've thought about it in an evidence-based way. Yeah. And that I think is really, really powerful.
Yeah, and just to add one extra bit onto that would be put it in your documentation.
Yeah. Document everything, please, because there's nothing more difficult than knowing, that staff inherently want to do the right thing, and that there may well be gaps in terms of knowledge, but write stuff down because then we can see exactly what your intent was within a case. You and I both retrospectively review cases, and it takes away so much pain. If we can read it, we probably don't even come to you to ask what happened. If we can see what's written down, it's probably resolved. You wouldn't believe the number that I look at that are documented well, that I never escalate, never go back to the crew, never have to do anything with, versus obviously those where I don't have those answers and we do have to do that. So we never want reviews to be a punitive thing. We always want to be able to reflect and learn from these things. Certainly I don't, as a senior manager, want to come and have to hassle and hound you for statements or an account of what happened with a patient, which frankly you might not even remember, because of the sheer volume of patients and sometimes the time that collapse between these things happening and the reviews coming up. So you can really help yourself by doing that, and we want to then just support reflection, support an ability to learn from the good, the bad, the ugly, and go from there, which sort of segues us nicely into a bit of a quick mention, I guess, of clinical supervision, because I think as paramedics as an ambulance service, we kind of have a bit of an authoritative top-down view on what clinical supervision might be. Now, coming from a mental health nursing background, it looks very different. So would you just elaborate a little about what that looks like and how we might approach that and what we can apply into the ambulance service?
So to give an example of what happened in my last clinical role, how I would receive my clinical supervision would be that my direct line manager and I would effectively go and sit in a room with coffee and biscuits and go through, on the times when I was holding a caseload, the caseload itself, let's look at what's going on with these patients. Are we doing the right thing at the right time? And when I was more working on the crisis side of it, looking what have we been doing, and what's been going on in my world with regards to the patients that I've been looking at. Clinical supervision, it sounds like it's I'm watching what you're doing and I'm going to mark you. That's not what it's for. It's there to help you to see whether actually you're making the right decisions at the right time, in the right way, and then helping you to find out what, if there is anything, what you need in order to be better at it. It is something that I think a number of other areas of healthcare probably do need a little bit of work on. By no means is
it's not just us.
Ambulance service. It is very much widespread across a lot of other aspects of healthcare. But it's one of those areas that I do feel that mental health care has actually got quite well.
Yeah, I would agree. I think my experiences of seeing that, and then more latterly, as I've specialised from being a paramedic into paramedic that does mental health, and obviously leads on it locally, I think there's real power, real utility in a true clinical supervision model, in working out for ourselves often, through a facilitated conversation, how things are going, what we're doing well, what we're not doing so well, reflecting on those spaces where we've got opportunity for learning, and actually the restorative side of clinical supervision. Because I think particularly in the ambulance service, we can get so hooked on, again, guts and glory, the gory realities of trauma and the messy things that people would never expect to see in an ordinary life, and we are exposed to day in, day out. Very often it's not always those things that seem to affect individuals as much. No, don't get me wrong, it's very much an individual thing, but I think we need to be aware that there are little cumulative effects. There are big effects from psychiatric illness. I mean, particularly if you are, seeing a lot of mental health patients or patients with mental ill health, that can have a real toll on your own well-being.
It can, and it helps to think about clinical supervision forms part of a package. There are three different, certainly in my background, there are three different types of supervision. You have clinical, management, and peer.
Yeah.
Or if you only have one of those, or if you only have two of those, you don't get a full picture.
Yeah.
But if you have the clinical looking at what you're doing as a professional, you have the management, so somebody looking at you going, actually, how are you doing as regards to how they feel that you're actually doing your job? And then your peer, in that you actually have people that you deem as a peer looking at what you're doing going, actually, you know what, you're doing all right.
Yeah. And I think there's real challenge in terms of doing that in the sense of joint experience, joint practice, particularly, within models of care, which are yourself potentially as a registered clinician working with an unregistered clinician who, may well have a lot of experience, but may not have the level of training, knowledge and skill to support, a conversation around that. That doesn't necessarily mean that you can't do it in that space, but the reality is that your paramedic peer perhaps might not be able to observe your practice, but it doesn't always need to be that. I mean, a discussion, a sit down, a chat, describing a circumstance and what you did and why you did it is sufficient to start having those conversations, isn't it?
Yeah, absolutely. Peer supervision doesn't mean somebody working alongside you. It is somebody who you deem as a peer that you can talk through what you have done, what you have been up to, what might have been affecting you. Some things, depending on how you want to do it, you can talk about things that you think that have gone down really, really well, and some things that maybe haven't been.
And I think the great thing really for peer supervision, it's not something you need a structure or a framework to do. It is something you can get off your own backside and go and find someone to have that discussion with, someone you trust, someone you want to hold you accountable to some of the learning and some of the opportunities that come out of supervision. Because again, as part of this whole reflective approach to professional development, there's an opportunity to take from the supervision a task list and go, right, these are the areas and things I need to improve, and these are the things I'm going to go away and do to do that. And actually you come back next time when you look at it and you go, actually, how'd you get on with that? Yeah. And actually just having that question, or just knowing that question will come, can sometimes be enough just to motivate you to go away and not just talk the talk, but walk the walk and do the work to improve your knowledge.
Absolutely. And even with regards to the management one, management supervision can be as formal or as informal as people and organisations want to take on. There is nothing wrong with sitting and having a chat with somebody that may be sitting on your management line about something that's been going on. That is effectively management supervision. It doesn't have to be hugely formal of please sit down, sit at the opposite side of the desk and let's talk through what you did last shift.
Yeah.
More a case of you might want to sit, not necessarily in a crew room, but sit to one side, just have a conversation with somebody.
Yeah.
That can, in many cases, be all you need.
Yeah, and I think it's just those conversation starters, even where there isn't a formal framework for that. It's the, boss, how do you think things are going for me at the moment? Are there any gaps that you're noticing in my care? Are there any opportunities? Are there things that you think I'm particularly good at that I could go and advance my skills a bit more? And that can be pretty brief, to be honest. It doesn't need to be an hour-long sit-down, but again, it forms part of that opportunity from a reflective practice perspective and a self-awareness perspective to go, right, let's use this opportunity, because people, frankly, people who ask those questions, if I'm being asked that question as a manager, I've got huge respect for that person as a clinician, because Absolutely. It shows a level of self-awareness, it shows a level of passion, of desire, of wanting to be the best clinician you can be.
It's also a case of holding us to account as managers as well.
Yeah.
Like, all of us should be receiving our annual appraisals, PDRs, whatever they're called in local areas, but these smaller conversations are what build on that.
Yeah.
So you have your one formal, if you want to call it that, a year, but actually there is absolutely nothing saying that has to be the only one.
Absolutely.
So do little 5-10 minute conversations with people once a month if you can.
Yeah.
Or more, because we should know as managers, leaders, what makes our people tick, and also where they want to go.
Yeah.
Because we should be pushing people to develop themselves if they want to.
Absolutely. We touched briefly onto the restorative side, and I just want to segue into kind of the staff wellbeing and opportunities for ensuring that people can access the right support when they need it as we bring this to a close. Tell me a little about some of the work you've done and the services you've engaged with for staff within SCAS and how they can access support if they need.
So, as with all organisations, particularly within NHS, we have our employee assistance programmes. These will look slightly different depending on which trust you belong to, which organisation you belong to. Using down to the basics of occupational health, etc., just to where there is a need for people to receive an additional level of support or care. It's again, people see occupational health as punitive. They're out to get me type moment. Actually, they're not. They're there to offer support and advice from a clinical occupational point of view to yourself and to the organisation as a whole. I'm going to give a shameless plug to the ambulance staff charity.
Yeah,
they
absolutely
are
heroes.
Absolutely superb. So, I'm not going to try and shout about all the things that they do because, quite frankly, I haven't got time. But anyone who does need that support or anything, just wants somebody outside of the organisation to just go and have a talk to, they are superb. Crisis service for them is available from the moment you start in the service. They have got a multitude of other aspects that are available to you after you've been in the service for a year plus.
Yeah.
Absolutely epic. They are brilliant.
And I think the most important thing to say is that all that information can be found on their website. So just search TASC on Google and you'll find that. And actually the crisis number is also there. So if anyone's in a position where they do need that urgent support, perhaps can't access local services, perhaps work quite closely often with those local services, TASC is a really great alternative to accessing some pretty immediate care. Now, obviously, there's always thresholds and boundaries and things we might need to consider around that. But if you, as a clinician in an ambulance service, are finding things difficult and you need someone to talk to, I think that's a really, really good starting point.
Absolutely. And it is very much worth saying it isn't just operational crews that can
absolutely.
access. It is anybody that works within the ambulance services. That's ops, call takers, corporate staff, backstage staff, anybody at all that wears the crown crest can absolutely access those services.
Absolutely. So I think TASC is such a good option for a lot of people. I just wanted to touch on one other which many people perhaps aren't as familiar with, which is NHS Practitioner Health. So actually, NHS Practitioner Health is a service designed again for those people who need longer term support, for perhaps access to talking therapies or perhaps slightly higher levels of input from equivalents to community mental health teams or even GPs, where we have those relationships with professionals, with GPs, with our mental health teams. And actually that support, that might be a barrier to getting that support for an individual. So search NHS Practitioner Health. They've got a wealth of resources, clinicians across the country, and access to pay for and support private therapies for periods if that's what's needed to support you to return into work, to return to full health, and to help you to thrive ultimately. And that's the point, isn't it? We want to come to work and thrive and actually make the most of it rather than just drudge through each day and have to deal with the impact of mental ill health or distress, psychological distress, moral injury, all these things that we are so at risk of in the ambulance service.
Yeah, it takes us back to the mental health continuum, of which there are multiple different versions, but I will refer to the AACE one because we have to stick to the party line. We want people to be sitting and thriving.
Yeah.
We recognise that's not always realistic, but let's be fair, that's where we want people to be. There are a multitude of services out there. There's loads of options available for people if they're in that need. Please use them. We highly recommend.
Absolutely. And to reference a podcast we recorded earlier, and depending on how we release these, this will either make sense or no sense at all. But actually, we want to make sure that people have conversations with each other and just ask the question of, how you doing? How are things for you at the moment? I've noticed you're perhaps a little bit withdrawn, or you struggled a bit with that job. Have that conversation, have the question, and as an individual, when you are asked that question, be willing to open up and be honest and to acknowledge when things are difficult, because it's not an easy job we do. It's not an easy world we live in, and there is a lot of support out there to get you from making ends meet, struggling, surviving, through to actually being able to thrive, to enjoy the role, to get back to the passion and the caring, empathetic nature that we all come into this job with, to get rid of the burnout, to get rid of the stresses, to get rid of the anxiety, and to truly thrive and to come to work to do the best for your patients.
Absolutely right.
Fab. Steve, it's been a pleasure to have you join us to discuss a wealth of things there. 1 through 6, we've touched on staff wellbeing, we've gone through supervision, we've touched on a whole number of things. What would be your one thing that you wanted to share with an ambulance staff member around the topic of mental health, as a parting gift?
My parting gift would be, please take the time to look after yourselves, because if you can't look after yourselves, if you don't look after yourselves, you won't be able to look after anybody else. So we look after ourselves in the same way as we would look after ourselves on scene. Let's do that on all aspects of ourselves so that we can then go out and look after everyone else.
Great. Steve, thank you
Thank you.